Welcome to Chiropractic Science, where you get to hear interviews with leading chiropractic researchers from around the world. Hear about chiropractic research from the authors in plain English, not through the media nor a middleman. My name is Dr. Dean Smith, and I am the host of Chiropractic Science. I am an associate clinical professor in the Department of Kinesiology and Health at Miami University, and I'm also a chiropractor in Eaton, Ohio. My research interests relate to understanding how chiropractic affects motor control and human performance. Today, I have the privilege of interviewing Dr. James Whedon. But before we get to that interview, I wanted to thank all of you who have subscribed to Chiropractic Science, and I'm especially appreciative to all of you who have contributed 5-star reviews on iTunes. iTunes really helps others find out about chiropractic science. So if you like the show, please take a second and write a review. It will support chiropractors everywhere. Well, I'd like to share a review by Dr. J. Nash, DC, on iTunes. And Dr. Nash says, energizing, informative, and accessible. I think that it's extremely important to stay current and to continue to learn. But with work and a young family, I find it challenging to carve out time to do this as often as I would like. I just recently started listening to Chiropractic Science podcasts in the car, and it's a game changer. The topics are current and timely, the guests are leaders in the profession, and there is tremendous value in hearing about the research from the researchers themselves. When I arrive at work, I always have a new tidbit to share with colleagues or an idea about how to apply or integrate the new knowledge and perspectives into what I do. I also appreciate how the guests weave threads that remind us to think critically about what we do and the quality of research that we are doing and using. I just finished the podcast with Dr. Ian Coulter. It left me re-energized with new questions, an interest in looking more closely at the original papers he discussed, and also at the research on the context of the clinical encounter across different professions. I'm excited about the research that is happening and how it will support the role of chiropractors in the broader healthcare context. Thank you to Dean and the guests for making the information accessible and easy to digest. Well, thank you for that review, Dr. Nash. I look forward to sharing your flattering iTunes review in a future podcast. Consider making a contribution to Chiropractic Science to keep these podcasts going. You can do so on our website, either by making a donation or by purchasing the evidence-based patient education slides presentation. We are also on social media, including Facebook and Instagram, so please connect with us there. All right, on to the podcast. Well, let's get on to the interview with Dr. James Whedon. Jim Whedon is the Director of Health Services Research at Southern California University of Health Sciences and adjunct instructor at the Dartmouth Institute for Health Policy and Clinical Practice. He holds a DC degree from Logan College and an MS from Dartmouth College. He has authored 33 peer-reviewed publications. He is advisor to the Project for Integrative Health and the Triple Aim, co-chair of the Research Working Group of the Academic Consortium for Integrative Health, charter member of the Academy of Integrative Health and Medicine, and recipient of the Jerome F. McAndrews DC Memorial Research Fund Award from the NCMIC Foundation. Dr. Whedon, it's a privilege to have you on the Chiropractic Science podcast.
Thank you so much, Dr. Smith, and thank you for inviting me. It's a real pleasure and honor to be here.
Well, we're excited to hear what you have to say and learn about your experiences in chiropractic and chiropractic research. So first, if you could tell the audience how you became interested in becoming a chiropractor.
Well, it was kind of a funny thing. It just sort of came in a flash. It wasn't like I went through, some kind of laborious process of figuring out what to do with myself. But I was just sitting on the beach one day wondering what to do with the rest of my life. And I happened to be sitting next to a guy who was a student at Life University studying to become a chiropractor. And we were talking and he said, well, why don't you become a chiropractor? And I thought, well, no, I would have me, a doctor. No, I don't think so. But within 24 hours, I was driving home, and I saw my whole life leading up to that, and I knew that I was going to become a chiropractor. And I did. I went back to school, got the credits I needed, applied, and went through the whole process, and the rest is history. But I did have an experience of chiropractic that was kind of interesting. As a young man, I was living in Cambridge, Massachusetts, and came down with a terrible case of low back pain and sciatica. It just hit me like a ton of bricks, and I had no idea what was happening, and nothing seemed to help, and ended up going to Cambridge City Hospital on a busy Saturday night in the emergency department and waited for like 3 hours. And finally, a resident saw me and examined me, and they took an X-ray, and they put the X-ray up on the old, the view box, and I could see it. And he said, "Well, there's nothing. You can't find anything wrong with you. Maybe you've got the flu." And I thought, no, this is not the flu. And that X-ray, I don't know anything about reading X-rays, but that doesn't look right, because there was this like kink in my spine. I thought, that's funny, but he's the doctor, so. And then I like pleaded with him for some kind of strong, pain medication, morphine, whatever. And he said, "Well, no, everything's locked up. I can't give you anything." And I was just begging, and finally he gave me something which just made me drowsy and didn't do anything. So that was Saturday night, and I endured Sunday. And Monday morning, I went to see my friend Bruce Whedon, who had a chiropractic practice in Harvard Square. Some of the listeners may know Bruce. He died suddenly a couple of years ago, but after he left Massachusetts, he had a very busy practice, again, down in Florida, and had a radio show, and he was just a tremendous guy and a wonderful chiropractor. So he examined me, he took my history, and then took films and put the film up on the view box again of my low back. And there was that kink again. And then he said, "Well, there's the problem right there. And lie down on the table," and he adjusted me, and that was that. I got up pain-free. So that was my first experience of chiropractic.
Well, that's a really cool experience, and I like the part about the beach. Maybe there's something about the beach as well in this story. That's really interesting. So you went to chiropractic college, and then presumably you got into practice. Can you tell us about your practice a bit?
It may come as kind of a surprise, although I'm all about evidence and research now, that I had a really straight chiropractic practice, just manual adjustment of the spine, and some of you may be familiar with network chiropractic. That's actually what I practiced for years. And just, suffice it to say, it wasn't exactly evidence-based, but patients loved it. I really enjoyed, providing that kind of basic chiropractic care, and had some, it was just a wonderful experience and quite a busy practice for a while. Although eventually, questions were just kind of nagging me, my left brain kind of kicked in, and I wanted to understand more about what was actually happening when I adjusted people, and that was part of the reason why I ended up eventually getting into research.
So are you still in practice today?
No, I actually haven't practiced for probably about about 4 years. I practiced first in Massachusetts and later in New Hampshire. And now I've moved to California, and I'm in research full time.
Okay, so how long were you in practice?
Well, I guess over a period of 25 years, most of that time I was in practice, either full time or then later part time in New Hampshire. After I moved up to New Hampshire, I had a home office, a smaller practice than what I had in Massachusetts. And I also went to work for Dartmouth Hitchcock Medical Center, which is the teaching hospital for Dartmouth Medical School.
Oh, that's really neat. So what is a typical day like for you these days?
Oh, well, I'm a director of health services research here at SCU, Southern California University of Health Sciences, where we train chiropractors and also other types of integrative healthcare practitioners, and acupuncturists, massage therapists, Ayurveda practitioners, yoga therapists, physician assistants. It's really quite a variety of disciplines here. And but as the director of health services research, I'm really doing a lot of administration. So a typical day may be working on a research proposal, working on a data user agreement for use of a research data set, an IRB application, maybe reviewing a manuscript or doing peer review. It's pretty varied and kind of fun that way. There's always probably several different projects I'm working on any given day.
Yeah, fantastic. Well, I want to dive into your research because it's just absolutely fascinating. You've been published in a variety of excellent journals, including Spine Journal, JMPT, Journal of Alternative and Complementary Medicine, Journal of Evidence-Based Complementary and Alternative Medicine, and so many others. But I'd like to talk with you about some of your most recent research today, and then talk about maybe some ideas for how you might be able to think about incorporating evidence into practice, given the wealth of your practice experience. So let's get started with one paper, and I hope this will be a good introduction to your research. And this is a paper called Relevance of Quality Measurement to Integrative Health Care in the United States from Journal of Alternative and Complementary Medicine in 2016. It seems like a common theme of your research is to improve access to health services that people need and want, and to improve quality through systematic care of acute problems and conservative upstream care of chronic problems. And I hope this paper can get us into that mindset. Can you tell us a bit about this paper?
Sure, I'd be happy to. So this paper came as a result of a collaborative effort from the Academic Consortium for Integrative Healthcare, which is a consortium of schools of integrative healthcare. Many of the chiropractic colleges, if not most, are involved, as well as schools of acupuncture, massage therapy, direct entry midwives, naturopathic medicine schools. And so we meet periodically and engage in various projects. I'm as a co-chair of the research working group for the collaborative. We sometimes get involved in collaborative research projects or publication projects, and that's what this was. It was more of a kind of a review and opinion piece as opposed to research, actually, but it came about because we wanted to kind of explore the topic of quality measurement and quality improvement in integrative healthcare, because the quality measures and continual improvement of clinical healthcare is really an integral feature of medical practice in the United States, conventional medical practice. But it's not common among integrative healthcare providers to be engaged in quality improvement. Certainly not with the level of intensity that you see in medical practices and in hospitals. So we just wanted to kind of initiate a dialogue about quality measurement for integrative healthcare, and kind of introduce the subject, because not much really had been published about it in the literature on integrative healthcare, and kind of just talk about what it is and examples of how quality measurement can be applied in integrative health, and talk about whether this is something that integrative healthcare practitioners should be doing or not.
Okay.
So it's really kind of an exploratory paper in that way.
Gotcha. When I was reading through it, you had some description in there about discriminatory policies that may prevent participation of integrative healthcare practitioners in quality improvement. Can you give us some examples of what that might look like and how we can try to tackle those issues?
I think probably the most salient example of that is an issue that pretty much every chiropractor is aware of, and that's Medicare and the restrictive policies of Medicare with regard to reimbursement for chiropractic services, i.e., they only reimburse for spinal manipulation and Medicare does not reimburse for examination, for evaluation and management services. And yet, Medicare does expect chiropractors to, practice, high quality health care. So there's kind of a discrepancy there, and it does appear to be discriminatory. And so I think that the solution to that seems, I think, obvious to most chiropractors. We would like to see, I think, at a minimum, Medicare reimbursing for evaluation and management services, which not only would be of greater benefit to patients, significant benefit to patients, but also would allow chiropractors to, participate in a little more meaningful way in quality improvement.
Perfect. What do you think are some ways that an individual chiropractor can help out in this pathway to try to get us, a different kind of legislation for through Medicare?
Well, we made some recommendations for practice and policy. We recommended that integrative health clinicians, educators, and researchers should engage in a dialogue, for starters, regarding the implementation of quality metrics appropriate for integrative health care. We recommended that conventional healthcare organizations should take steps to reduce barriers to participation in quality measurement by integrative practitioners. And finally, we recommended that integrative healthcare organizations should take steps to encourage clinicians and administrators to engage in quality measurement. Now, I would like to sort of introduce a caveat there, though, and that is that, the possibility has been raised that we may be killing quality by measuring it. Right? So if clinicians are spending all their time kind of checking off boxes and documenting the quality of their care, and that means less time spent with the patient, it kind of calls into the question this whole process of quality measurement. If it becomes so burdensome as to adversely affect, the doctor-patient relationship and actually the quality of the care. So I think we need to think about that and think about how this whole issue applies to integrative healthcare. And just, I wouldn't, being out of practice now, I wouldn't presume to, make explicit suggestions about what chiropractors do or not do in practice. But I think it's something we need to talk about.
Yeah, absolutely. And I'm still in practice part-time though, but I can attest to the burden of the documentation. And like you said, it seems being discriminated against, and we don't get paid for exams, and yet we're held to the same accountability in terms of our note taking and whatnot. So, it would be great to see some of these things change, and I really appreciate the ways, the suggestions that you've given for the individual chiropractor to try to get into this. Another series of papers we're going to be talking about, but the next paper is the association between use of chiropractic care and costs of care among older Medicare patients with chronic low back pain and multiple comorbidities. And I'll just say that anytime I see an article come out and it's by you, I just get excited because I know it's going to be high quality and it's just going to be exciting. So,
thank you.
Yeah, can you guide us through this paper and give us your take on what the significance is?
Oh yeah, sure. Well, first of all, I think I should point out that I was not the lead author or the lead investigator on this paper. The lead author investigator was Bill Weeks. who's a medical physician at Dartmouth, and he also has an association now with Palmer College, and has done some research work in collaboration with Christine Gertz. As was this project. It was kind of a multidisciplinary project. It was conducted at Dartmouth, where we analyzed Medicare data to explore these associations between chiropractic care and cost of care. So, like a number of studies I've done, it was a kind of retrospective observational study using these big, really enormous Medicare databases that come from Medicare claims. So we had studied over 72,000 older patients with chronic low back pain, and these were also sicker patients, so they had multiple comorbidities. We're really primarily interested in looking at costs. And what we found that among these patients who used only spinal manipulation during their chronic for their episodes of chronic low back pain, they had lower overall costs of care. They had shorter episodes, and they had lower cost of care per episode day. So we felt that these findings were significant in light of the particularly in light of Medicare's concerns that kind of chronic concerns over the years about the costs of chiropractic care, the cost simply for the interventions, the chiropractic interventions, but this study pointed out that there may be cost offsets. So we don't want to look at just the cost of the interventions, but what are the overall costs of care? And we found that they were lower for patients who actually used chiropractic.
Okay, terrific. In the paper, you used something called propensity scores, and I wasn't too familiar with that. Could you tell us what those are exactly?
Yeah, it's kind of an obscure point, isn't it? Propensity scores are sort of a statistical device that are meant to reduce bias in research. And so there are various kinds of bias, but there's a kind of bias called selection bias, and that happens when the two groups, the two groups that you're studying, your primary group and your comparison group, are not the same. And this is likely to happen if you're comparing people who use chiropractic versus people who don't use chiropractic care. And the idea being that these chiropractic patients may be different. They may be different with regard to their beliefs and behaviors. So to use kind of an example from a more recent study we did that I think would be really easy to understand, it seems quite likely, if you're studying the use of opioid medications, right, among chiropractic users and non-users, that maybe the patients who are using chiropractic really don't believe in medication, and that's why they're using chiropractic, right? So if you find a difference among the groups, it's possible that it's not the treatment, chiropractic, but the patient who wasn't going to be using medications anyway because they don't believe in them. So that's called selection bias. And the way propensity scoring works is you try to equalize your groups by measuring the propensity to use chiropractic, right, among your population, and assign a score that kind of quantifies that propensity to use chiropractic. And then it gets entered into your analysis, into your regression model as a factor. And by adjusting for that propensity score, you equalize your groups. And it sort of approaches having a randomized trial where the groups are equal because they've been randomized. but we can't do that in this kind of claims study. We can't randomize because we're looking back at something that already happened a few years before. So there's no randomization. So in short, I hope that clears it up. It's basically it's kind of a statistical device to make your groups equal.
Great. Yeah, I think that was an excellent explanation. I appreciate that. To me, the results suggest what we talked about previously regarding upstream care, of conservative care in particular for these chronic problems. How significant do you see these results, and how do you think a program like Medicare, or maybe more broadly the healthcare system in general, would fare if we started to implement chiropractors earlier into care?
Well, I think the evidence is really clear, and it's not just from this study, but for multiple studies over the last 10 years or so. These studies keep coming up and saying the same thing, that if you use chiropractic care first, that your cost outcomes are low and your clinical outcomes are better. There's less escalation of care. Over and over, this is coming up. And, and that's, it's no accident that the guidelines, the clinical care guidelines coming out of the American College of Physicians, et cetera, put spinal manipulation as it's cited as first-line therapy. In fact, pretty much all the first-line therapies for low back pain in these, clinical guidelines are now non-pharmacologic therapies. So it shouldn't be any surprise, and so the problem, I guess, is that you can have clinical guidelines and you can have evidence and expert recommendations, but it doesn't always filter down into practice. And I think one of the principal reasons for that actually comes back to access and lack of insurance reimbursement sometimes, the very rather limited reimbursement under Medicare, is a case in point. So many where you have many kind of conventional medical doctors who recognize those guidelines, may recognize the value of chiropractic or acupuncture or massage therapy as maybe a safer and more preferable alternative to, say, medication, particularly opioid medication. But the patients may not have the access to coverage that they need. And so even those who would like to refer, their hands are, kind of tied in a little bit because the patient's the practical options for patient access are not there.
Mm-hmm. Yeah, for sure. In looking at the literature that you've done and maybe what you've read, what type of services do you think that chiropractors perform should be covered? And I know this is just a hypothetical question, but we talked about exams, and do you think if we covered exams for chiropractors and maybe some other therapies in addition to the chiropractic adjustment, do you think that would still be financially showing some benefit?
Well, yeah, yes to exams. It seems obvious that Medicare really should be covering evaluation and management services. It's the right thing to do. As far as other services, under Medicare, it makes sense to me that chiropractors should be able to practice up to their full legal scope of practice and provide whatever services they're legally authorized to provide. And under that scenario, if a chiropractor didn't want to provide a certain service, that could be their choice. But for those who do want to kind of practice full scope, that would also be allowed. So and the scope of practice varies by state. So I I wouldn't want to get in, again, I'm not practicing anymore and wouldn't want to make specific recommendations, but that kind of makes sense to me, that just for Medicare to allow the full scope of practice. And as far as how that would affect costs, yeah, we should evaluate that. But under Medicare, we cannot do that, although we did have a Medicare demonstration project a few years back, and that's a whole other subject, and we actually did a reanalysis of that demonstration project at Dartmouth, and that's how I began to work with Dr. Weeks and Dr. Gertz. It was that reanalysis. But that's a whole other subject. I don't know if we want to get into that one.
Well, I wanted to ask one other question about this paper before we go to the next, and that is specifically about the multiple comorbidities, because I'm not aware of too many other papers that have actually looked at this, and I think it's just an amazing topic to think about. What happens when we see, these are real people and they have real problems, not just spine issues, but they have other things going on too. And I wanted to get your idea of how, in terms of expenses, maybe in terms of effectiveness, I don't know, whatever you feel comfortable talking about. What did you see with these multiple comorbidities?
Yeah, so these were older patients and they were sicker patients. And they had a range of I think if I remember correctly, the patients, many of the patients had psychiatric comorbidities as well as chronic diseases, kind of the usual suspects, heart disease and diabetes, et cetera. So these were sick patients. And what we found was that for those who use spinal manipulation for their low back pain, the vast majority of which is provided by chiropractors under Medicare, by the way, what we found was that overall costs were reduced. So total Medicare costs for all services were reduced for those patients who used chiropractic or spinal manipulation for their low back pain. So one might hypothesize then that there was some effect upon these other comorbidities, but we didn't get into that level of detail. So that would require further analysis to know exactly where the costs were reduced. Although we did find that we did look specifically at the psychiatric problems and that was not a source of the cost reductions. There were no lower costs for psychiatric conditions. But as far as the other comorbidities, we don't know. But we do know that overall costs were reduced, so that would lead one to possibly hypothesize that the spinal manipulation or the chiropractic care had some effect on the comorbidities as well as on the low back pain.
Yeah, wow. I mean, it just opens up another whole line of research. So another lifetime of research devoted to that topic of comorbidities. So, wow.
Yeah.
My mind is blown with all of this research. And the next couple of papers, again, talk about new lines of research. I think this is another pathway. And this is, you had two papers. One was talking about association between utilization of chiropractic services for treatment of low back pain and the use of prescription opioids. And the other paper that I wanted to talk about in this segment was association between utilization of chiropractic services for treatment of low back pain and the risk of adverse drug events. So, wow, these two studies are huge. Chiropractors have been talking about these studies, and I'm on Facebook and I see it all over Facebook, and it's just brought up a lot of attention to the topic. So, I don't know, where should we start on these two, Doc?
Well, yeah, certainly, the ongoing opioid crisis is something that everyone's concerned about, and was kind of kind of sparked an interest in doing, these studies. But well, I guess a little bit of background is in order here. I just want to note the very broad support for the notion of using non-pharmacological therapies for low back pain. Right? I mentioned the clinical guidelines that most of you are aware of, I think, for clinical guidelines for low back pain being primarily first-line non-pharmacologic therapies. There have been other, kind of quasi-governmental bodies, expert panels, departments of the government that have all, come out with recommendations over the years for non-pharmacologic therapies for pain. The Centers for Disease Control, the U.S. Department of Health and Human Services in general, the Institute of Medicine, the Joint Commission, the list goes on and on, where these respected advisory bodies are saying use non-pharmacological therapies for pain, and specifically for low back pain. But what you don't see, although you have these recommendations, what you don't see is a whole lot in the literature about non-pharmacological therapies as a potential solution to the opioids crisis. If you read the scientific literature about addressing the opioids crisis, what you'll read about is using different drugs, using less of the same drugs, different prescribing practices, different practices at the pharmacy, controls over what physicians do, what patients do. But you don't see kind of the thinking outside of the box that I think, may just come naturally and, occur, sort of obviously to many chiropractors, which is that, well, what if we go upstream and don't use drugs to treat pain? So, and it's just not part of the conversation. So, and even though, we as chiropractors maybe sort of be able to connect the dots, that's not really the way research happens. It happens in baby steps. So if you want that, kind of perspective to be considered, it needs to be part of the scientific evidence base. So this was a baby step in that direction. And I should point out that we did not establish any causal connection between use of chiropractic care and reduced use of opioids, nor did we establish such a connection between use of chiropractic care and reduced incidence of adverse drug events. But we did establish an association or associations between those things. We found that when we studied claims data for the state of New Hampshire, we found that the adjusted likelihood of filling a prescription for an opioid analgesic was 55% lower among recipients of chiropractic care compared with non-recipients. We also found average charges per person for opioid prescriptions were also significantly lower among recipients of chiropractic care. And then in a very similar study, we looked at the risk of adverse drug events. And we found that the risk of adverse drug events was significantly lower among recipients of chiropractic services, also as compared with non-recipients. Although there were some limitations to the drug event study because the data was kind of non-specific with regard to the drug categories. So we weren't really able to uncover a specific relationship between chiropractic care and reduced use of opioid-related adverse events. That was more, I think, a deficiency of the particular data we were accessing. That the information, the specific information we needed, wasn't there in the data.
Gotcha. Now, I know these data sets came from New Hampshire, and do you have plans to expand these to different states?
We do, and I'd like to point out that this research was supported by the Council on Chiropractic Guidelines and Practice Parameters very generously, that first round of research, and now we have a second round of funding expanding on this theme, and we're repeating the study in New Hampshire as well as in Massachusetts and Connecticut. This time with a little bit more rigorous methods, and 10 times as much as large a population base. So we're going to be looking at these same questions, with again the focus on the opioids, association with opioid use, and we're also conducting the study nationally under Medicare, and that study was funded by a small foundation out here in Southern California.
All right. I can't wait to be able to read those reports when they come out. It would be great to get some prospective observational studies to track clinical outcomes regarding the use of opioids and adverse drug events. How do you think clinicians, chiropractors, can get involved in these kinds of studies or support this form of research?
Yeah, I think that would be terrific. And I guess my suggestion, and I have to confess, I have no connection with this organization. I just know of it. But I think that Spine IQ is a relatively new project that's getting underway that allows or invites field doctors to actually contribute their data to a nationally based registry, which will allow some, pretty broad-based research on these areas. And so, even though the field doctors may not be actually doing the research, they're contributing it by contributing to contributing their data. Which is something that's very much needed. So spineiq.org, check it out and see if that's something that you might want to participate in.
Fantastic. How can chiropractors who are in a position to influence policy best utilize this type of data?
Well, I think simply sharing the results of these studies with colleagues, with patients, with policy makers, in third-party payers, anyone and everyone who's interested. But don't. I would urge people not to overstate the conclusions. Sometimes we're our own worst enemies by virtue of kind of a little bit of over enthusiasm, which I have to confess to myself, as having been in chiropractic practice for many years. I recognize the benefits, I recognize the value, and maybe I'm a little bit biased and might, might have a tendency to overstate, right, and make statements that are not supported by the evidence. So the evidence, alone, as stated in these papers, is compelling. And so I guess I would just sort of issue that cautionary note, which I issue to myself on a daily basis when I compose manuscripts and so forth.
I know exactly what you're talking about. Sometimes we have to restrain and just control the bias. Very good. This might be a little bit of a different question, but I'll ask it anyways. How might you suggest chiropractors interact with patients concerning prescription drugs like opioids and still stay within their scope of practice?
Yeah. Again, not being a chiropractic in chiropractic practice actively anymore, I kind of have to pass on this question a little bit. Again, I would say, share the results of research with your patients, and as far as anything else, everything's varied by state, right? So the scope of practice varies by state. So I'd hesitate to make any blanket statements about that.
Sure. Yeah.
Addressing a national audience.
Absolutely. Yeah. I appreciate that. Okay. So I want to talk about two other papers, and the next two deal essentially with stroke and traumatic injury. So risk of stroke after chiropractic spinal manipulation and Medicare Part B beneficiaries age 66 to 99 with neck pain, and risk of traumatic injury associated with chiropractic manipulation in Medicare Part B beneficiaries age 66 to 99. So could you guide our listeners through these couple of papers, and maybe what was the motivation behind this as well, and some of the key points that you found?
I think safety, we have the old dictum, above all, do no harm. And that's really been turned on its head, I think, by modern medicine in a way, because, safety is such a huge issue in conventional medicine. Conventional medical care is the fourth leading cause of death, or is it third now? I don't recall. There was a recent study out of Johns Hopkins 2 or 3 years ago that showed that, despite years of quality improvement and quality measurement and safety studies, et cetera, that the problem hasn't gotten any better. It's worse. And of course, we hear these issues come up as chiropractors. Particularly the issue of the association between cervical spine manipulation and stroke, and it's often. We often hear these concerns about safety. So this is not something that we should ignore, because it's the right thing to do, to be very concerned about patient safety, and also with this issue that just kind of has kept coming up. And I got particularly interested in the safety of chiropractic care when I was working at the Dartmouth Medical Center, and I had access, because I was the trauma registrar and had access to all the records of trauma patients that came in. There was a case that came through where a patient had been adjusted by a chiropractor and developed a spinal epidural hematoma, and we wrote that case up as a case report in collaboration with neurosurgery. And I think that for me kind of sparked, kind of an acute interest in the safety of chiropractic care. So that was kind of the origin of these studies. Again, these were studies of Medicare claims data. And the study of the association between spinal manipulation and stroke, I think the kind of unique contribution we made to this literature, which is already quite extensive on this subject, was that we studied older Medicare beneficiaries, and we found that the risk of vertebrobasilar stroke, which of course is the only kind of stroke that can be, we can sort of articulate any kind of reasonable mechanism between spinal manipulation and stroke. We can only do that for vertebrobasilar stroke. We found that the risk was extremely low, and that the small differences in risk between patients who saw a chiropractor or those who saw a primary care physician for their neck pain were probably not clinically significant. Because first of all, the absolute risk was really low, and then the differences between those tiny numbers were also very small. So that was the outcome of that study. The outcome of the study about risk of physical injury following spinal manipulation was a little bit more clear-cut. and we found that within 7 days, the risk of injury to head, neck, or trunk within 7 days was 76% lower among those who visited a chiropractic office versus those who saw a primary care physician for a neuromusculoskeletal problem.
Wow. That just blows my mind. So
yeah, these were, most previous studies of safety in chiropractic were mostly kind of systematic reviews derived from case reports. But there were, of course, with stroke, there were case control studies, very well conducted case control studies. But a lot of the literature was really not. Well, you just can't do a clinical trial on this because the risk is so low. You would have to do a trial for, 10 years, and it cost you $20 million. So that's not an option. But this was, I think one of the contributions we made here was that we had very large databases, and still found, again, really low risk. The risk is that what we found was just, it's not an issue.
Gotcha. Well, I just read a few days ago on the website there at Southern California University of Health Sciences that you were recently awarded 2 NIH grants. So congratulations on that.
Thank you very much.
Yeah,
we're pretty excited about it.
Yeah, I guess that's amazing. So the studies, as I read them, one was comparing spinal manipulation and drug treatment of chronic low back pain in Medicare recipients, and the other was analysis of association between cervical spine manipulation and cervical artery tears. So if you could give us any sneak peek, so to speak, on these projects, that would be awesome.
Oh, yeah, sure. So the first project is actually an award to SCU to study this association. Again, both studies, again, are actually Medicare claims analysis studies. So retrospective observational studies. The first study, I think, but the unique thing about this, we're comparing chiropractic care with prescription drug therapy. But what's unique about this actually is that we're looking at long-term care of chronic low back pain. There are lots of studies of chronic low back pain, right? But in many clinical trials and various kinds of observational studies, the clinical trials, which are considered, the more of the gold standard for evidence, rarely go beyond a few weeks or a few months. There have been very few clinical trials that go as long as a year. But if you think about it, people with chronic low back pain, pain tends to be not only chronic but recurrent, and patients may be seeking treatment for a whole lot longer than just 3 months, sometimes for years. But the evidence that we have for long-term treatment is pretty scanty. And certainly for opioids and NSAIDs, there are serious safety concerns. And the effectiveness over the long term is very uncertain. That's also true, in fact, of spinal manipulation, which certainly under Medicare, if you think about maintenance care and the issues that Medicare has with maintenance care, kind of highlights the a certain amount of uncertainty about the value, at least among the Medicare administrators, but certainly among many others as well, about the value of the long-term chiropractic care for chronic low back pain over a period of a year or more, sometimes many years. So what we're looking at here then, this comparison, because we have Medicare claims data, we can examine over a period of multiple years, and we hope to shed some light on this issue of long-term care and what's effective and what's safe. The other study was actually primarily awarded to Dartmouth, and I'm a co-investigator on that study. And yes, it is yet another study of the risk of cervical artery dissection, vertebral artery dissection, as well as carotid, following spinal manipulation. And I guess what's distinctive about this study is the size of the data set that we'll be using, where we'll be studying over a 9-year period, not only older Medicare beneficiaries who, as you may recall from the discussion a few moments ago, the risk tends to be low among older Medicare beneficiaries for vertebrobasilar stroke. Age seems to be protective for some reason, actually, for that particular issue. It's more of a problem for younger people. But we're studying not only older Medicare beneficiaries, but younger Medicare beneficiaries, which, as I'm sure you know, may realize, are mostly people who are disabled. Disability is a reason for Medicare coverage. And so we're going to be studying not only the older beneficiaries, but also the younger disabled Medicare beneficiaries. And many, of course, are disabled for spinal problems. And many receive chiropractic care. So much larger data set, more inclusive population, and really, really rigorous methods for observational research using not only the kind of pseudo-randomization of propensity scores, but also instrumental variable analysis. And kind of just looking at this data every which way and trying to tease out associations that may have not been apparent through other studies.
Wow, I have a smile on my face. This is going to be this is going to be neat. Oh, well, I want to keep talking about this stuff, but I do want to ask one last question, and that is, a goal of this podcast series is to motivate and assist practitioners and students alike to pursue research careers in chiropractic science. Can you offer any advice to aspiring chiropractors or students who want to go down this pathway?
Sure, I guess. Well, first of all, I just want to, encourage anyone who thinks they may be inclined to pursue a career in chiropractic research to really encourage that. I found it very, very fulfilling and very exciting. Although kind of in the midst of research, it seems, might seem kind of a little humdrum, a little boring at times. But when you get those answers, it's pretty cool. So, yeah, I've found it very fulfilling. And I guess what I would say is that research, it's not a one-man show or a one-woman show by any means anymore. It tends to be collaborative. So, if you want to do research, you kind of need to start building relationships and collaborative relationships with people and institutions. It's really going to help. Of course, research is not cheap. You need funding. So, as researchers, we're always thinking about where our funding is going to come from. How are we going to do that? And it can be pretty challenging. But there are lots of opportunities. There's actually a lot of money out there if you can find it, and a lot of interest in integrative healthcare broadly and in chiropractic specifically, because we do offer so much value and such a wonderful alternative, I think, in many cases to conventional care. And I think a lot of conventional physicians are recognizing that as well. So things are really kind of going our way in a lot of ways, although, kind of in practice, in the trenches, maybe it doesn't seem like that day to day, and I know it can be very challenging. But, not only in practice, but for researchers as well. But so I guess, develop relationships. It really helps to be associated with a school, an institution, a university or college of some kind, preferably a chiropractic college, where you will have colleagues with all kinds of knowledge and experience that will come in real handy when it's time to engage in your research project, because no one person can do this alone. You need folks to bounce ideas off of, and people that they can put their heads together with you and kind of critique your ideas and your proposals and your manuscripts and so on. So align yourself with a chiropractic college. See if you can make some sort of contribution as an adjunct faculty member for starters. It doesn't you don't necessarily have to live near such an institution. With all these electronic alternatives now available to us for communication, the physical distance is not as important as it used to be. So don't let that be a barrier to kind of exploring these relationships. And then the other thing is research kind of funding, particularly federal funding from the NIH or what have you, can be really challenging for the chiropractic schools, which are smaller institutions, tuition-driven, not wealthy either in actual cash or in resources, particularly the kinds of resources that are required for research. So also forging collaborative relationships with conventional medicine, with medical schools. And when I say that, I really mean specifically with people, with physicians and healthcare practitioners and researchers, PhD researchers at other schools. That can be, you can really put together a very fruitful relationship between a chiropractic school and a medical school that can benefit both institutions tremendously. And then finally, kind of within that context, find a mentor. Find someone who's been successful in the research field and attach yourself to that person and learn from them. That can be probably the most important thing that you can do, is find someone who's willing to and able to guide you along the way, because it's just a whole new field, and I got into it without having the slightest idea what I was getting into, but fortunately I had a mentor who knew what I would need to learn and was familiar with the process of becoming a researcher. So I guess that those are the main things. It's all about relationships, really, when you come down to it. And if you have good ideas, I just urge you to follow up on them and see if you can turn them into fundable and executable research projects.
Very, very good advice. I love it. And I thank you so much for taking the time today and coming on the podcast. I really appreciate it. I know a lot of people are going to love listening to this. And so thank you so much.
Oh, well, thank you. I really appreciate the opportunity to, share a little bit. Everybody kind of likes to talk about their own work, right? So
absolutely.
Really nice. So thank you so much. My privilege.
Oh, great. Well, I hope we can talk in the future about some of these studies that you mentioned today. I look forward to catching up and learning about those studies in the future.
Sounds good. I'll look forward to it too.
Thanks again for listening to this episode of Chiropractic Science, where we got to hear from Dr. James Whedon. I hope you learned as much as I did during this interview. We'll have many great interviews coming up, so stay tuned.